Hi, everyone. This is Katie Couric, and you're listening to the Cancer Matters podcast with Dr. Bill Nelson. Like us on Facebook, facebook.com/Hopkins-Kimmel, and follow us on Twitter at Hopkins-Kimmel or at Bloomberg-Kimmel.
Good afternoon. This is Bill Nelson, director of the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins, and we're here today with two women, Armine Smith and Jeannie Hoffman-Censits, who are experts in the world of bladder cancer and have really begun to focus on bladder cancer as it arises in women. So I'll start out with both of you. What is bladder cancer? Why do people get it? Why do women get it in particular?
So bladder cancer is a cancer that arises in the urothelium, which is the lining of the inside of the bladder. It's actually much, much more common in men than in women. It's the fourth most common cancer in men and the eighth leading cancer cause of death in men. But in women, it's a lot less common. And it's surprising that even though that this is such a common cancer, most patients, most families, most men don't ever hear about it until they're diagnosed with the disease.
So why is it more common in men historically?
I think it's a really good question that we don't completely understand. It's a cancer, like many cancers, that's associated with smoking. So some people think, well, potentially it's related to that. We know that there's some occupations where you have a higher risk of having bladder cancer and compound that with smoking.
Chemical exposures, that kind of thing?
Exactly, that kind of thing. Industries like being in the painting or dye making industry, those kinds of things. Generally, those are industries where men, happen to have those jobs more than women. But we don't completely understand. We know that when patients present with bladder cancer, they often have the same symptoms, whether or not they're men or women. Blood in the urine is the most common presenting symptom. Sometimes frequency, needing to go to the bathroom a lot, or getting up in the middle of the night, or urgency, feeling like you can't quite get to the bathroom. And of course, we know that there's other things other than bladder cancer that cause those symptoms, right? Having a big prostate or other kind of prostatic issues, or having a urinary tract infection. So oftentimes, depending on gender, there can be a delay in that workup and understanding whether or not somebody actually ultimately is diagnosed with bladder cancer.
So that's a good time to turn to you, Armine. When someone shows up, a woman perhaps with the blood in the urine, or a man with blood in the urine, what type of evaluation is typically undertaken? What do you do next?
So the interesting thing is, usually the pathway to get to urologist is very different for men versus women. So I would say in majority of the times, men would go to their primary care physician, then they get directed right away to the urologist to get the appropriate evaluation. Women, it's a little bit more convoluted. So because urinary tract infections are more common in women, because women are more used to seeing blood in the urine, it takes a little bit longer for them to make their way to the urologist. Initially, they may go to the primary care, they may go to the GYN, and they might get some antibiotics in the minute clinic to treat the presumed UTI, urinary tract infection, and then they end up in the urologist's office. So the evaluation for men and women is the same. Usually we'd have to screen their kidneys, make sure there's nothing coming down from the kidneys, no abnormalities.
And these can be things like kidney stones.
Which
usually there's other reasons you figure out you've had.
Right. And then screening the bladder, which is usually requires a look in the bladder or something of that nature. So that is pretty much the most typical evaluation to rule out the bladder cancer.
And then when you find someone has a bladder cancer, you've looked in the bladder, perhaps done a biopsy, and or collected cells that come out with the urine from the bladder and seen cancer there. What are the next steps you take? What does a bladder cancer usually look like?
So it's interesting, when people think of cancer, they think of cancer as just one disease. And bladder cancer, any cancer comes in different varieties. And the bladder cancer it has different pathways. So it can be more aggressive, less aggressive. So depending on the grade of it, the aggressiveness of it, and depending on how deep the bladder cancer is invading into the bladder, the treatments are very different. So usually for the less aggressive kind, we leave the bladder in place and we go in and shave down the areas of the abnormal cells and maybe give some chemotherapy into the bladder or immunotherapy in the bladder. When the cells are more aggressive, but they still are superficial, so they're not growing in deeply, still we leave the bladder in place. We go in and shave down the cells and give some immunotherapy or chemotherapy. It becomes much more difficult to deal with this when the cells grow deeper into the bladder wall. So when it becomes something that's called a muscle invasive, when it's growing
so the
deeper.
bladder is basically like a balloon with a muscle around it so it can squeeze the urine out, right?
Exactly, yeah. So it's a few layers of the bladder from inside to out, about 3 layers, and the cancer obviously grows from superficial to deep. So once it invades the muscle, it becomes a muscle invasive, and it's treated usually by more radical surgery, or we sometimes get inventive in how we treat these cancers. It's a very individualized decision.
Well, that's when the concern for that it has spread to other sites in the body or invading other nearby tissues. That's what you're thinking and what you're worried about when you take that more aggressive approach to treatment, right?
Right.
So I'll turn to you. How is that changing? I was at one point a genitourinary oncologist, and the first disease that we really took on a number of years ago was bladder cancer, and we thought we were doing well by using chemotherapy, usually a fairly large number of drugs given over a fairly aggressive couple of days. And we were starting to see cancer shrink, and we were patting ourselves on the back, assuming that if we continued on this road, we'd have it cured in no time. That's not what happened. How has that kind of treatment changed?
Yeah, so bladder cancer has changed so much in the last couple of years. First of all, especially in patients that have advanced disease, this really is a multidisciplinary approach, which means that oftentimes people are seeing more than one doctor, getting more than one type of therapy. So, Armine and I aren't sitting next to each other here talking to you by accident. It's because we work closely together every day in the care and management of patients with this disease. As she referred to, patients that have disease invading into the muscle layer of the bladder, those patients, they have a benefit in terms of their overall survival. Patients live longer and do better if you give them a medication prior to removal of the bladder. It's a drug called cisplatin. It's been around forever. And, if patients are fit enough to get that medicine, and not everybody is, it's a tough medication to give, as you know, have to have good kidney function because these drugs are metabolized as well as potentially toxic to the kidneys. They can induce things like peripheral neuropathy or numbness or tingling in the fingers and toes, changes in hearing. Someone has to be fit and robust. They have to be able to kind of, get up and about, take care of themselves every day in order to really, for us to be clear that they can tolerate that therapy. So it's not for everybody. So that really, in the perioperative or around the time of a big surgery, and what we call in the first line setting for patients who have metastatic disease, forever and ever, that was the best treatment that we had. And up until about a year and a half ago, that was it. And what has really changed and revolutionized our field is FDA approval of immunotherapy. So where there was really nothing in what we call the second line therapy in terms of treatments that we really had a lot of enthusiasm about after platinum, now we have 5 treatments that have FDA approval, which is really exciting. And these are all drugs that are these immunotherapy drugs, which help kind of reactivate or energize the immune system to essentially recognize a tumor that may have just been sitting next to, but now all of a sudden can actually recognize the tumor, gather up its other immune cells and start to fight off the cancer. It doesn't work in everybody. In bladder cancer in the second line, it's about between a 15 and 20% response rate. But these drugs, this class of drugs, has also been tested in patients where they can't get that platinum agent, where they are not good candidates for chemotherapy. And so for patients with metastatic disease who we feel are not going to be really well served by getting chemotherapy, we can also use these immunotherapy drugs in the first line.
And of course, the clinical research you see now is trying to get a bead on why these drugs are beneficial to some folks and don't seem to help others as much. Is there something that can be learned from that you can engineer a different version of immunotherapy from the ones that don't benefit well enough? Back to you, Dr. Smith. So surgical approaches, particularly the ones that urologists have pioneered, to a variety of different things are changing. There's a bias to, when possible, do minimally invasive surgery, robotic surgery, and the like. Where is the surgical approach to the bladder headed?
So the paradigm of the surgery has changed a little bit too over the past few years. So, and mostly in the muscle invasive bladder cancer space. So I would say when I started training in urology, the answer to this was surgery, removing the bladder, removing the surrounding organs, and that has changed.
A big surgery, right?
Exactly, exactly. A lot of debilitating, very body-changing surgery. And now the chemotherapy has kind of come forward before the surgery, so that's changed. Also, we're starting to learn that in some patients it's possible to do bladder preservation. So use multiple treatment modalities to leave the bladder in place but treat the cancerous area. And that's another example of multidisciplinary approach to the bladder cancer with the medical oncologist, radiation oncologist, and surgeons. The paradigm of removing the bladder in women has changed a lot too. It used to be much more invasive with removal more of the organs, but now we're learning that we can save some of the organs and that benefits the patients in the long run. I think those are kind of the majority of things, and I think we're as the time is going by and there's more interest towards the bladder cancer, we're learning more of who can be safely, kind of the bladder be left in place, and who can have more minimal surgery. Now, as far as the open surgery versus robotic or laparoscopic surgery, a lot of times the verdict is out. It's the availability of technology, it's the availability of the specialists, and every surgery is as good as the surgeon who does it. You really have to be proficient and you're comfortable with these types of surgeries. I know there is a big push to do minimally invasive surgery all throughout the country, all throughout the world. In bladder cancer, this has not been as proven beneficial as in, let's say, other urological surgeries. So I think we still kind of do half and half open or robotic surgery if you look all across the nation.
So here's a question just from the news just in the last couple of weeks. In the New England Journal, there was a randomized trial and a larger survey of follow-up from the Commission on Cancer, the American College of Surgery, related to cervical cancer surgery via laparoscopic or robotic-assisted approaches by an open approach. And as you mentioned, without that much evidence, it was adopted fairly quickly, and the evidence at the moment is worrisomely suggesting that the more limited surgical approaches may actually not treat the cancer as effectively as the open approach. And looking through those papers and not being a surgeon, of course, I was trying to figure out what could have been different in terms of, did they inflate something with a gas, move something? Is there an exposure that you need? And the pelvis seems like a busy area to operate. Is it difficult to go chase down some of these kinds of things with limited surgery approaches in the pelvis?
No, I don't think it applies to the bladder.
Very good doing in the prostate.
Yeah, we're usually pretty good. And I myself do both open and laparoscopy, and I feel like the exposure is just the same, the space is just the same, and I think sometimes robotic gives you even a better exposure than open surgery would in a very narrow spaces, small spaces. So there was a study. It's very hard to have, as all know, it's very hard to get good prospective randomized studies in medicine, especially in surgery. But there have been a few studies that compared these laparoscopic or robotic approaches to the open, and they showed something that's called non-inferiority. So they're just as good as the open surgeries. It's just, it's really the skill and the mindset of doing a surgery to eliminate the cancer instead of just doing the surgery to do the surgery.
So you already mentioned issues for women with bladder cancer in terms of how they come to medical attention. They may not be as concerned with a tiny amount of urine, blood in the urine, as a man might be. When they visit their primary care physician, they may be given an antibiotic rather than sent immediately to a urologist, so they'll come a little bit later. The surgical approach, the neighborhood of organs and tissues around the bladder, slightly different in women than in men, so surgical approach is different. And the sheer quantity of experience, perhaps in the clinical research that had been done before, probably oversampled men if there were any other differences. What other kinds of things do you guys think about when you think about approaching women with this disease?
Well, I think the first thing is really just listening. A lot of women, because there is a delay in their diagnosis, will often come to us with very different stories than our men that are diagnosed with bladder cancer. women are used to seeing blood in the bathroom. This is often not, something that's completely shocking to them. And, as Armine said, the pathway to get to that diagnosis is different. When you look across big populations of patients, the time and all these studies are retrospective, which means we go back in time and look at either big institutional databases or national databases. But the folks who have actually looked at this, there is a statistically significant difference in the time that a woman takes to get to a urologist, and be that from their own feeling that maybe it's just a urinary tract infection, or the different doctors that they're referred to, versus men, and having to wait 3 to 6 months and then find out you have a bladder cancer diagnosis, it's devastating for people. So it's a very different story than for men, who oftentimes already maybe have a urologist phone number in their pocket, or have seen somebody for prostate cancer screening, so they get in earlier. And so those stories are very different, and in part, I think, inspired me to take care of more women with bladder cancer. So that's something that we definitely think about. The other thing we know is that women have statistically higher numbers of antibiotic prescriptions that are given to them for presumed urinary tract infection in the time leading up to diagnosis. And as we're learning more about this whole different, exciting, and really compelling field of immunotherapy, we're also learning about the things that can impact immunotherapy. And one of those things may be antibiotics and this thing called the microbiome, which is these organisms that live within our body and are in homeostasis, with us, and how antibiotics can affect that. So that's a question that we really don't know the answer to. Do those antibiotics leading up to diagnosis, do they affect the disease itself? Do they affect response to therapy? We just don't know.
Well, one of the goals I know of many of the people and commercial entities trying to build molecular detection and diagnostic tools out of detecting DNA, if you can find a hair follicle at the crime scene and try and figure out who was at the crime scene. Can't you find when a cancer is misbehaving somewhere with the DNA in the bloodstream, or in this case, perhaps in the urine? And I know there was a great deal of interest in that industry for the bladder cancer use, to find something that could be a point of care test to deploy rapidly when someone thought to have a urinary tract infection, so it would have to be inexpensive. And can you say, perhaps in women who are a little bit older, but can you say, this is worrisome, and get to a urologist faster? So what you're saying is that would be very useful if people could devise that.
In bladder cancer, we have the huge advantage of having urine that can be screened for cancerous changes. And it's very easily accessible. It's not a blood draw or anything. So it's been a huge amount of interest, as you say, to find new biomarkers. The problem with the biomarkers is they sometimes over-detect and sometimes under-detect. So there's a variety of biomarkers out there in the market, and I feel like every 6 months a new one is out. It's just that we have the quest of finding the good one, the perfect one that can replace invasive tests such as cystoscopies, look in the bladder, etc.
And some of these, do you commonly use any of these in monitoring people? As you mentioned, you'll find some with bladder cancer, and you'll be able to remove the tumor that you can see. You'll give immunotherapy or chemotherapy directly into the bladder, and then hopefully that's successful, but you'll want to monitor them carefully, and you look in the urine. I guess you look back into the bladder periodically. What's the optimal way to do that? And do any of these new tools help with that?
So I would say some of these tools do help, but they don't take place of the cystoscopy. So a lot of the times it's just the extra step, and a lot of the times just because of the cost to the patient, to the medical system, I end up skipping that. So when I diagnose a patient with a bladder cancer, I tell them we're going to be good friends for the next few years because we're going to see each other very frequently, and it just ends up being a very long-term relationship. So a lot of the times the monitoring goes from looking back in the bladder every 3 to 6 months to once a year, and repeated treatments into the bladder. That's for the non-invasive, for the superficial bladder cancer, and that goes up to 5 to 10 years. And for the invasive cancers, even after treatment, we do need to monitor them also regularly with scans, looking at the rest of their body.
And hear from both of you a little bit about as cancer treatment gets more and more effective throughout the various cancers that are treated, the next thing that people start to think a lot about is can we improve the lives of the survivors? And obviously bladder cancer that needs to be treated very aggressively by removal of the bladder, you've changed the way that they're going to think about themselves and manage urination and other things. And when the bladder can be spared, there are different opportunities in survivorship. What are the key survivorship issues that the two of you see that we already are doing better than people might think, and where do we need to do even better in the future?
Well, I think the one thing that we can say about bladder cancer is that there's a lot of work to do, and I think there's a lot that we can improve over time. One of them is, I think, what Armine alluded to a little bit earlier, is that this is a big disfiguring surgery that patients have to go through, and the question is, can some patients keep their bladder? This is a big question in our community and in folks who take care of bladder cancer. So we just opened and participating in, I think, a very important trial. There are some tumors that we know have a certain change or mutation in something called DNA damage repair. And those tumors tend to respond better to cisplatin-based chemotherapy than those that don't. And we've learned this based on kind of looking back in prior clinical trials of preoperative chemotherapy with this drug called cisplatin. And based on what we've learned, actually two trials are ongoing now looking at this. Patients are getting standard of care chemotherapy, but during the time of chemotherapy, we're looking at this sequencing, what's called next generation sequencing, looking at the mutations or changes in each tumor. And then at the end of that, for patients whose tumors have these defects, and they have a complete response to therapy, both from a scan standpoint and looking inside the bladder, those patients can be offered surveillance. Now, this is radical. This is very different than standard of care, to be clear, in the setting of a clinical trial. But I think it's a first step in thinking a little bit outside of the box in terms of not only just a survivorship issue, but trying to do better based on specific tumor characteristics, really individualizing that treatment to patients. That's one of many different clinical trials that we have ongoing as we learn more about the molecular characteristics of tumors and how to target those characteristics and not just try a different chemotherapy.
So other issues of survivorship, and as people live longer, we face these more and more frequently, and it's definitely an understudied area, and I think it requires more attention. So we know that people with urological cancers have a lot of anxiety and a lot of depression surrounding their diagnosis and subsequent follow-up. So I think it's both Jeannie and I have a particular interest in this as well, in trying to optimize and find better solutions and bring the community together in helping these people cope and live their lives. So even with the bladder in place, after the treatments, a lot of people have anxiety around the times of their screenings because you never know if you're going to have the cancer or not. After the treatments into the bladder, people are left with some symptoms, some bladder pain, some urgency frequency, maybe lasting, maybe transient. So that's a big domain that needs to be studied as well. The caregiving after a big surgery, after removal of the bladder, living with the external bag or having a new bladder or a stoma or something like that, it requires a lifelong commitment and monitoring, and it's also a big source of anxiety. And some people do develop late complications from the treatment, and we just need to learn more about it so we can provide a better care to these patients.
So which of these innovations excites the two of you the most? I mean, what seems very exciting is to recognize that bladder cancer behaves a little bit differently because of the way it presents and some of the surgical issues and other things in women than men, perhaps even initiated by a different cause, maybe not so much smoking and naphthalene dyes or what have you, but something else. So getting focus on it seems very exciting. What excites you two about moving forward?
Well, I think one thing that excites me is just having kind of the time and the space to think about this. So as part of one of the many missions of the Greenberg Bladder Cancer Institute is to have a space for this, is to start thinking about this and talking about this, because the incidence of bladder cancer is so much higher in men than in women. We haven't, I think, before kind of separated that group out and really thought about women differently. And I think in part, as you mentioned before about the success of immunotherapy, I think it started to open us all up into thinking about and really understanding too the molecular characteristics of different kinds of bladder cancer. It started to open us all up into thinking about bladder cancer as very different diseases, including the unique things that happen in women. One of the things that we're doing, and I believe this is probably the first of its kind, is we're putting together a academic meeting about women's bladder cancer that'll be coming up next year. So that's pretty exciting, getting people together in the Baltimore area from all over the country, potentially the world, who think about this. So there's not that many of us who do it, but to get us all together at an academic meeting, kind of lay out what the problems are and think about how to focus research going forward is important. We need to do this as an academic community because the ratio of men to women is high, meaning there's not that many women that present with bladder cancer, that it's important that we think about collaborating moving forward to understand the subset of patients a lot better.
And this is the kind of thing that the Greenberg Bladder Cancer Institute, David McConkey, who's the leader of it, wants to do, is really probe all aspects of bladder cancer and bring people across the country who can make a difference together. What do you see coming that's exciting?
Well, I'm just excited to have that the bladder cancer is getting the attention it deserves. It's getting funding it deserves to have better studies, and I'm very excited to have collaborators and the Greenberg Institute that brings the collaborators together. To me, every cancer behaves slightly differently, and I think there is a big future in sequencing and genetics and finding other things that are affecting the cancer progression in the body that we haven't really thought about. So not thinking of the cancer as a mechanistic disease, but more of the biology of it and the forces at play to either fight it or let it take over the body. So I think sequencing and I think these new research studies that we have ongoing are going to make a big dent in the understanding of the cancer, the bladder cancer.
Also, the late Bernadine Healy, the first woman who directed the National Institutes of Health, was a cardiologist, of course, and in looking at this whole collection of cardiovascular research on fats and all this kind of stuff, and recognizing that all this was done in clinical trials only involving men, she said, we need to fix this. This can't be your father's NIH. That was the line she used. And so what the Greenberg Bladder Cancer Institute has embraced, this is not your father's bladder cancer. This is one where women are affected and need to be helped as well, and you two are leading the way to do it. So we've been on the scene today with Dr. Armine Smith, a urologist, and Jeannie Hoffman-Censits, a medical oncologist. The two of them are focused on bladder cancer, particularly bladder cancer in women, and starting to make some strides. They're people to watch.